Let's go ahead and get started. So welcome to the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Tuesday, July 16th. So hope you guys are having a good week thus far. I am trying to re-enter from vacation and it's proving to be challenging. So bear with me. All right. So on the call today, let's see, from the STS side of things, who do we have joining me today? So we have myself and Carol Crone. We have Chastity, Emily, Leslie. We have our adult consultant, Melinda, and Nancy Honeycutt, our adult database manager. We have Addie, Bono, Dr. Meyer is on, and Paul Meehan as well. So thank you everyone for joining the call today. I appreciate it. In terms of the agenda, I'm just going to provide a super brief STS update. I do not have any major updates from our last call, and then I'll turn things over to Leslie and Chastity, and they are going to be presenting on ascending aorta replacement case review. So we will have some polling questions, so be sure and be ready for that. So, and then we'll finish things up with Q&A. So if you do have any questions, please be sure to put your questions into the Q&A. And we do have that raised hand function enabled. So if you'd like to just ask your question, just please raise your hand. We'll unmute you. Just ensure that your microphone is enabled on your end. All right. For STS updates, July training manuals posted and available out on the STS website. Our spring 24 harvest, the data analysis is complete, and IQVIA again is has uploaded the data into the platform. We are currently in the user acceptance testing phase, also known as report QC, is in progress. So the core group and some of our surgeon leaders are in the process of testing and reviewing the reports. The current plan is to review the lesion specific reporting next week. So in terms of report release, I do not have an exact date, but we are hoping that the spring 24 harvest analysis will be available to you all sometime next month. So again, I will share more information, specific dates as soon as I get them, but we're hoping to have that available to you all sometime next month. The fall 24 harvest is currently underway. We're accepting surgery dates, or the surgery dates included in that analysis include July 1, 2020 through 6/30/2024, and that harvest close date is scheduled for September the 27th at 11:59 p.m. Eastern. Again, just the harvest schedule. Of course, we have AQO coming up in September. AQO is scheduled for September 11th through the 13th in Nashville, Tennessee. If you've not already registered, I encourage you to go ahead and register. And if you will be attending in person, go ahead and get that room reserved so we can get that that discounted rate, or the AQO rate actually. Also, Emily did want me to mention that the agenda is now posted on the STS website. So if you would like to go out and take a peek at what we'll be covering at this year's AQO, that agenda is now posted on the STS website. And that is all that I have from the STS side of things. I'm going to turn things over to Leslie for our ascending aorta procedures presentation.
Thanks, Leanne. Hi, everyone. I hope you're all doing well and enjoying summer so far. And if you did get hit with the storms, you are safe and power is restored quickly. We are going to talk a little bit about ascending aorta procedures today. We notice a ton of FAQs come in about these procedures, and it's not always crystal clear in the training manual how to describe the procedure that you're actually doing. We have a couple examples of cases just occurring on congenital patients under the age of 18, and then we have one on a patient over 18. So I just want to give everyone a little heads up. We will be doing some polling questions just on kind of which procedures to pick for the congenital portions. And then for the adult, we're just going to kind of go through portions of the data collection form to sort of summarize. And Melinda and Nancy, I think, are both on the call, and hopefully we'll be able to jump in if I screw anything up. So we will get started. Here is our picture of the aorta. Leanne, next slide. We're going to be talking about procedures kind of in a range of locations on the aorta, but just for quick summary, down here is the aortic valve where your leaflets are. This is the annulus. Next slide. Up to the aortic root. Next slide. Arch procedures will be here across the top. Notice I skipped the ascending. Next slide. So where we're focusing today is right here in this section, the ascending aorta. And there's a variety of procedures that could occur in this area. And those are the ones we're going to touch on today. The first being an aortic dissection repair, if it occurs in this location. However, when I was reviewing, I had a ton from our adult database of, not a ton, I shouldn't say that, that's terrible. I had some from our adult database that were dissections, but none that were just congenital cases. And I think that makes a lot of sense. So we're going to not talk into those cases so much today, since that's generally a more adult specific procedure. And I also found that it's a little bit more descriptive. It's, in my opinion, a little easier to see in your medical record, this patient has a dissection and they're having a repair. Whereas some of these other ones can get a little bit, the verbiage can be a little different based on your chart or what options we have in the database. Next slide. So we're going to start then with the aortic aneurysm repairs, and we're going to start with a case scenario. Next slide. So this is our 13-year-old patient with Marfan syndrome who presents with aortic root aneurysm, a dilated ascending aorta. She is the first member of her family with this condition. Genetic testing was completed with variants noted in FBN2, FBN1, and FLNA genes of unknown significance, and further genetic review is pending. Next slide. So what is the patient's diagnosis that we should list? Is it Marfan syndrome, aortic stenosis supravalvar, aortic aneurysm, or aortic root dilation?
About 50% have responded to the poll so far.
Okay, come on. We can do better than 50. Okay. Maybe not. We can go ahead and cut it off if it's.
Want me to end it? Okay.
Yeah.
I'll end the poll. We're at 64%.
Okay, and that gives
That
us
works.
a pretty good, awesome, a pretty good summary. The majority of people picked aortic aneurysm, which is correct. Aortic root dilation looks like it was the next best choice, but unfortunately we don't have that specific diagnosis in our database. It is not aortic stenosis. And then Marfan syndrome is true, but not a listed diagnosis in the congenital database. So we can go ahead and move on to the next slide. It is aortic aneurysm, which also includes pseudoaneurysms, and these are included if the aneurysm occurs anywhere from the annulus all the way around through the length of the aorta. Next slide. That's just highlighted, I think, with a circle on my next slide, but this diagnosis is actually going to encompass both that aortic root aneurysm as well as the ascending aorta dilation. Next slide. And just real quickly about why Marfan was not the correct choice. One, it isn't a listed diagnosis in our database for the diagnosis table, but you will collect this whether or not the patient is under or over 18 in the syndrome section of the demographics table in the database. And then if it happened to be an adult patient over 18, it's also collected in lots of other places like aortic valve etiology or your aneurysm etiology. Next slide. Forgot I put that here. This is just where it goes in the syndrome table. Next slide. Okay, moving on from aortic aneurysm cases into another ascending aorta case. This one is a 37-year-old patient with bicuspid aortic valve, aortic stenosis, aortic insufficiency, and ascending aorta and aortic root aneurysms. Next slide. So which should not be listed as part of the diagnosis list? Aortic valve bicuspid, aortic, neo-aortic, or truncal valve insufficiency and stenosis, aortic aneurysm, or aortic, neo-aortic, or truncal valve other. Like we need some background tunes.
Oh, sorry, that's me.
No, it's okay. Just while
I
we're
was like,
waiting.
do you hear me typing? I could, you know.
I don't want to hum the
I could-
Jeopardy
I could
tune,
hum
but that's
or
always
sing
what I
for
think
you guys.
of.
You don't want me to sing, trust me.
Me either.
All right, we'll go ahead and end
Kind
it.
of slowing down. Thanks, Emily. You can end it there.
All right.
So
Interesting.
next slide.
Oh, there we go.
Answer which should not be listed as part of the diagnosis list is aortic valve bicuspid. And that is because it is not a choice offered in the diagnosis list. The patient does have stenosis and insufficiency, so that is correct to list. Aortic aneurysm, also correct to list. They have both an ascending aortic aneurysm as well as a aortic root aneurysm. And then aortic, neo-aortic, or truncal valve other could be listed if you wanted to somehow capture that this patient had bicuspid aortic valve, because there's no other way to do that. Next slide. Sorry, just giving a little explanation that for anything not specified, you can use this other, I'm blanking, other code, other diagnosis to kind of be an all-encompassing diagnosis. Next slide. Okay, this patient undergoes a Ross procedure with reinforced autograft and an ascending aorta replacement. Next slide. Which procedures are we going to list in the procedure list? Ross, aortic stenosis repair supravalvar, aortic aneurysm repair, or both A and C? Awesome.
Looking good.
Yeah. Okay, we can go ahead and thanks, Emily. It looks like the vast majority of us chose the right one. That is A and C. We did both a Ross procedure as well as an aortic aneurysm repair. Next slide. Perfect. It's just a quick description of the Ross procedure. This is when we take the pulmonary valve, put it in the aortic position, and then use a conduit valve conduit in the pulmonary position for the Ross procedure. And then next slide, a thoroughly non-descriptive definition for an aortic aneurysm repair, meaning a repair of an aortic aneurysm by any technique. So both of those qualify. Next slide. And because this patient is over 18, we're going to run through just a few things that are a little bit different for data collection for adult patients versus what we would look at for congenital patients. And for this, like I said, we're just going to look at data form, the data collection form fields. So next slide. Starting with the diagnosis section. Next slide. Because we chose 610, which was aortic stenosis and insufficiency, these are going to automatically pop up for you. So I just really quickly, before we get too far down this is going to look different likely than what you're entering in your vendor, but this data collection form is something we all have access to. So I want to use this to kind of go through and give examples. But I tried my best to not put a ton of parent-child things in there that wouldn't be relevant in this case. So to go back, we chose 610. And so these will pop up for us. We're going to answer things about the degree of insufficiency and stenosis, and if we have any measurements available, and then as well as a little more description on the valve disease itself. Next slide. And I didn't give this level of detail just in our overall summary, but I just did screenshot in some of this information from our echo so that you would know where to go and how to find this information. So if you kind of scan through this, you will find that the patient has severe valve stenosis and mild valve regurgitation. We do have some measurements available, and it also goes on to describe the disease. Next slide. So I filled some of those things in here for us. If you were reading really quickly, it did say in the little screenshot that I gave you, likely bicuspid valve disease. And so I did go back in through other documents, other surgeon documentation, other things in the medical record to confirm bicuspid valve disease, because of course, likely or probable or looks like are not quite good enough for us to use as a confirming diagnosis. So I did double check. It is bicuspid valve disease, so we've entered that as well. Next slide. On to the procedure itself. Next slide. Okay, so this is in the, it could be in a couple of different sections in your vendor, but kind of in the intraoperative section of the data collection form, we're going to get into specifics for adults and what types of procedures were performed. So this was not a CABG. We've answered no. It wasn't a procedure. It was a procedure on the aorta. It was a valve procedure. I missed a check mark, but there was not an explant. It was a procedure on the aortic valve itself. And so you also answer that you did something at the same time on the aorta, a little bit of a duplication there, but that is kind of how we know to then open up the different sections further to the data collection form. It's a no for a mitral procedure. It's a no for a tricuspid procedure. And it's a yes for a pulmonary valve procedure. And those were all planned. Next slide. Quick reminder, next slide. For all Ross procedures on adult patients over 18 or 6,575 days, all Ross procedures will be collected as an aorta procedure, an aortic valve procedure, and a pulmonary valve procedure. But just as a reminder, just the same as it was for congenital patients only, we do not add any separate pulmonary valve procedure codes like in that table. Okay, next slide. Moving on with other case types, there's no other cardiac procedures to include, no other non-cardiac procedures to include, and it was not an AFib procedure. Next slide. Getting into the pulmonary valve procedure itself, this is, I think, pretty much exactly how it has always been for congenital patients. This is a pulmonary valve replacement. It was not a transcatheter pulmonary valve replacement. We did have an implant. It was commercially supplied. It's a homograft. And then I included on the next slide just a quick little screenshot. I don't know how everyone's medical records look. This is how mine looks. So I can go in, find out the type of valve it was, the model number itself. Sometimes I get the size in the same place. Sometimes I have to look in the op note, but all of those little things you will fill in as well in this section. Next slide. And then you will move on to the aorta section. And again, just as a quick note, you don't fill anything out in the aortic valve section alone because you did something at the same time as the aorta. So all of this falls in the aorta section. Family history of the aorta, there was none. The genetic history is they have bicuspid valve. They did not have any prior interventions. So these trial fields will all be no. Next slide. And the current procedure does not include the endoleak involvement. Next slide. There's no infection or trauma for the current procedure. The presenting symptom here found in the H&P was worsening fatigue and exercise intolerance, so we chose other. Next slide. Primary indication is the aneurysm, again, bicuspid. I don't have any other details. There was no rupture. And then the location of the maximum diameter. I put in the snippet of our measurements again for my hospital, and especially for adult patients being done by congenital surgeons, kind of with our congenital team in the children's hospital. we do not always have the greatest level of detail at all, really, especially for adult patients, it seems. And so I did have to go back to our team and our surgeon and just sort of narrow down exactly where that ascending aortic measurement was taken to make sure I got the right spot. But again, something we encourage everyone to do, if you don't have an open dialogue with your surgeons, your team right now, please try to do so, because there are things that we're just learning over this last year. We've not really had to look for a lot of these fields in the past. So we've had a ton of open conversations about things that we need to be documented or documented a little better whenever possible, so that we can answer these questions as appropriately as possible. Next slide. This I just threw in here probably to give myself a little breather and also not to overwhelm anyone, but this isn't the training manual. This starts on actually page 803. I think I have the wrong one up there, but it's a great picture. I love this little diagram of the aortic root and ascending aorta, just to kind of show different parts of it. And then it goes on to describe all of the zones. We're just talking about this zone 0 right now in this talk, but it goes on to describe other ones, give lots of more descriptive information as well as diagrams. So if you need help kind of determining those zones, as you probably already know, there's a lot of information available in the training manual. Next slide.
Oops, I lost my cursor. I'm sorry.
It's all right.
It disappeared on me. Where did it go?
Water.
Oh, there it is. Found it.
A lot of talking. Okay. Okay. This is just moving on through additional procedure information. You're going to answer this the best you can. If it's unknown, it's unknown. Again, as we've mentioned in the training manual, don't guess. If you can't find it or you don't have the information, it's okay to leave it blank if there's not an unknown option. Right here, we're moving into other parts of this procedure. So root archinomae are both no. IMA is NA. I think a lot of this is no. More measurements again. This is coming from, this was the preoperative echo. So I have the treated zone measurements. I have measurements on the zone proximal to the treated zone. I don't have measurements available on the zone distal to the treated area. These will be found in your op notes, your H&P, lots of different testing that's available. Next slide. This is for the intervention itself, the aortic valve. It was, or root, yes, planned. Aorta, it was a replacement, not a transcatheter replacement, surgical replacement, other type. Next slide. No annular enlargement. This is if you do a Ross cono on an adult patient, this is where you would enter that as a cono. This was a root procedure, so this is where we're entering that. We finally get to say it's a Ross itself. It's a root replacement, composite valve conduit, and then autograft with native pulmonary valve. That's your Ross procedure. Direct to root prosthesis, the buttons for coronary implantation, and no major root reconstruction. Next slide. Okay, and this part here is your ascending aorta procedure. So you will say yes, and this is where you'll enter in the information you have about where the proximal and distal sites were. There was no extension, no branch reimplantation, and then no other surgical operation on the descending aorta. I just put in a little snippet of our operative note to show where this information came from. Next slide. Mostly no's for us for the additional procedure information here, but this is where we're going to enter the graph that we use in the ascending aorta. So yes, you entered or you inserted a device, but it was not the valve or valve composite graft. Next slide. You will enter then, so this, oh, sorry, my dog just jumped up on the desk. You'll enter in here. Again, this might look different for your vendors, but the important part that I wanted to point out here is that you're going to enter kind of 2 lines or 2 times for each graft. So for us, the proximal site was just below the STJ, and then it ended at the STJ to mid-ascending aorta. So then it was a surgical procedure, it was successful, and I have the model number. That's the same model number for the proximal and the distal site. It's 1 graft entered twice. Next slide. 1 graft listed twice. So you're going to list once the proximal location, once for the distal, and then the information, implant method, outcome, and model number. Again, this might look different in your vendor or however you enter your data. Next slide. And then if you happen to have more than 1 device implanted, again, you'll have a proximal and a distal, or however many you have. Next slide. Okay. We'll move on now to an aortic stenosis supravalvar repair. Next slide. And we're back to a congenital patient. This is a 10-month-old patient with Williams syndrome, supravalvar aortic stenosis, pulmonary stenosis, left coronary artery stenosis, severe mitral valve regurg. Patient requires a patch augmentation of the ascending aorta, a pulmonary valve repair, patch augmentation of the left coronary artery, and a mitral valve repair. Next slide. Which is the best procedure to choose for a patch augmentation of the ascending aorta? Is it the Ross procedure, aortic valvuloplasty, aorta other, or aortic stenosis repair supravalvar? Okay. Looks like it's kind of slowing down on enterers. So for the most part, it's 3/4 of us got that right. It is the aortic stenosis repair supravalvar. Just quickly, the aortic valvuloplasty would be down at the valve. That's okay.
Sorry.
Ross procedure, again, as we talked about, is when you take the pulmonary valve, put it in the aortic position, aortic position, and then put in a new valve conduit in the pulmonary position. Aorta other is general, but more descriptive would be the stenosis repair. Thank you, Leanne. Techniques including patch aortoplasty included there in the definition. And that is one of the things that we get questions about. It doesn't say always, sometimes it does, but it doesn't always say we did an aortic stenosis repair at this level. It'll say we did a patch augmentation or we replaced the ascending with a graft. So those are the things that we need to just watch for while you're abstracting these cases. Next slide. Okay, other procedures performed include pulmonary valvotomy, supravalvar pulmonary stenosis repair. How should the pulmonary valvotomy be captured in the procedure list? As A, pulmonary valvuloplasty, main PA reconstruction, valve surgery other pulmonary, or pulmonary stenosis supravalvar repair. Looks like it's slowing down again, so we can go ahead to the next slide. And the answer is pulmonary valvuloplasty. I also put a screenshot of this definition, next slide, just to show that it does include a range of techniques, including pulmonary valvotomy. Next slide. So now how should the supravalvular pulmonary stenosis repair be captured in the procedure list? And the same options: pulmonary valvuloplasty, main PA reconstruction, valve surgery, other, pulmonary, or pulmonary stenosis supravalvular repair. Okay, so I did try to trick everyone a little bit on this one. I apologize, it probably wasn't that fair since we were concentrating on the terminology and the aortic stenosis. But in our database, there isn't an option to choose that exact phrasing, pulmonary stenosis supravalvular repair. So the correct answer here is the main PA reconstruction. Next slide. And that is described, I just put the definition again, reconstruction of the main PA. Next slide. Okay, aorta other. Chastity and I were reviewing cases, and we did not have aorta other procedures that weren't adult, and we didn't want to bring another adult procedure to this call. But what we did realize is that there is a lot of need for sort of this area to kind of dive into. So what we would like to do are bring back some examples in our next webinar and continue sort of case scenarios on specifically on the aorta for now, but both for congenital and adult patients. So I think I think that's the last slide, Leanne. Will you check?
Yeah. Yeah, that's the last slide. I'm sorry.
We can go to some questions, and then as people kind of start thinking about and digesting this information, obviously we'll just keep it open.
Yeah, we just had a couple of questions. Nancy, I know, Paul, I don't know if you were able to answer this one, but Nancy was asking about physicians getting that error for missing physicians within IQVIA.
Yeah, that's a known issue in the IQVIA platform that's being worked on. Keep an eye on the notifications area. That's where we will put up a message saying when that's taken care of. For right now, those records, so this is specifically for the message saying, let me make sure I'm saying the wording correctly. Hold on a second. And I had it right here a second ago.
No matching information found.
Hold on, Paul, I'm trying to bring up the known issues.
Yeah, that's what I'm trying to look at which one it is.
Is it April?
I had it here a second ago.
What you're looking for, we can hop to the next question.
Yeah, okay. Yep.
Yeah. So Chastity Leslie from Amy, she said she thought bicuspid valve was a modifier diagnosis for aortic valve pathology.
I think when you say modifier, it's probably referring to something that's in the long list, and it's not a term available in the STS shortlist database. So although you can enter it in your vendor software, it's vendor specific, and it would map to an acceptable shortlist term, which I believe, correct me if I'm wrong, Chas, I don't have the long list, but I think it's the aortic valve other.
Correct. That maps to aortic valve other. So STS would never see the bicuspid aortic valve modifier, but when you submit your data, what they would see is aortic valve other.
Excellent. Brooke, is there any consideration of adding a specific diagnosis for aortic root dilation within the database rather than coding aortic aneurysm?
Great question, Brooke. Thank you for bringing this up. We obviously, as I mentioned, get a ton of these questions. It's on our list, I think, for the next version update. But obviously we can't add new procedures or new diagnoses in between versions. So we have a list of things that have been suggested. Those are then reviewed with the core group, data managers, surgeons, task force, and then some will get chosen to be added to a future version.
Awesome. Jess, maybe you can take this one. What is the long list and what is the purpose of using the long list? I've never heard of it.
Great question, Elizabeth. So the long list is something that was put out not by STS, but it has more granularity in the diagnosis and procedure terms. And so I think there's only one vendor at this point that uses it. And you're able to use it if you use that vendor, and you don't have to use it if you use that vendor. It's your choice. So I think the strengths of it are if you do a lot of research and you need some more granularity on what type of, subtypes of certain diagnoses or procedures are really important to you, then I think the long list is useful. STS does not use the long list. What is acceptable to STS is what is in your data collection form. And that's all STS sees. So even if you are a long list user and get all that granularity with your diagnosis and procedures, you are analyzed the exact same way as someone who just uses what we call the short list or the list put out by STS. And so that's kind of the purpose. And, you can talk to people about why they do or don't use the long or the short list if it were something that you wanted. But I think you have to have the specific vendor. So not all vendors offer it. Does that help, Elizabeth?
Yeah, she said yes. She said thank
Okay.
you. Perfect. Kathy. Oh, go ahead, Paul.
Yeah, I was going to say I did get the text of the message. So if you get the message that says specifically, no matching surgeon entry found, that's an indication that it's an issue on the IQVIA side, and that is in the works of being resolved. And even though it says the record has been skipped, it wasn't skipped, it was uploaded. So as long as there's no other issues with the record, it gets uploaded fine. We don't have an estimate of when that's going into production, getting that fix put into place. So the plan is when it gets put into production, you should keep an eye on the notifications. We're going to put a notification up saying that the fix was put in place. That's
Awesome. Thanks, Paul.
Mm-hmm.
All right. Leslie, did you want to take Kathy's question? Oh,
Wasn't on mute or wasn't off mute.
there you go.
Some absolutely fair feedback. The point of this one was to show that sometimes we see things phrased in the medical record that aren't options in our database, and it's important to go back and check those definitions. But totally fair that if we list bicuspid and people think, yeah, it should be bicuspid, then that's what they're going to lean towards choosing in a poll. So I hear you. Thank you for the feedback.
Kathy. Thanks, Leslie. Next question from Sam. What type of procedure would get categorized as aorta other?
Good question, Sam. So I reviewed a couple that were an adult procedures, which I didn't really think fit, and we wanted to get some more information from our adult colleagues before we went into it. One in particular was an ascending aorta replacement, but it wasn't for an aneurysm. It wasn't for dilation at any level. It wasn't for a dissection. It wasn't for stenosis. It was sort of a prophylactic replacement. It was a really confusing case, and it just only fit other. I'm sure people have examples, but of course, because it's an other category, it's going to be less common. Jess, do you remember any of yours that were aorta other off the top of your head?
The only one I can think of is where we replaced an ascending aorta, but it was not for supravalvar stenosis or aneurysm. And so sometimes we do it as a part of other procedures, and that's where we're hitting aorta other.
Okay. Next question. Marina said, how about patching the innominate off of the aorta?
As an aorta other? Yeah, if it doesn't, I think if it was adult, there are ways to describe where the maybe not. I think as a procedure list, that would probably be an example. But again, it's hard without, complete scenarios. If there's other things going on, it might fit in other buckets.
Oh, she said this was in a child. She was just clarifying.
How come I can't? Oh, I didn't scroll down far enough.
Oh, no, that's it. She just,
So yeah, I would probably say aorta other.
let's see here.
I'm gonna look up that question now while if you want to go to the next one.
Which one from?
Proximal. Explain how you were able to get the measure for sequence 3790 in the Ross since the aortic root and all of the ascending aorta was repaired or replaced. How did I know the proximal measurement or the measurement of the zone proximal to the treated zone if everything was replaced? Good question. I think it was from a preoperative echo. So perhaps not.
I don't know. I was just trying to go back to, I don't know, trying to find the slide.
Right, because I think these measurements are asked for prior to repair, right? You're looking at the disease of the,
I think it's one more slide back, Leanne.
This one?
No.
No.
yeah, that has your ascending aorta measurements.
That has the measurements, but the actual 3790, I think it's a little further down in the.
Oh, I'm sorry.
37, oh, right here.
Proximal in the pre-op echo. Oh, because the whole zone was treated. Is that what you're asking?
How you get a
So maybe I
measurement.
shouldn't have entered that, Melinda. Does that make sense? Does that
Well,
question?
I'm trying to understand the question. How were you able to get a measurement for 30?
I think she means 3800, that measurement, the 24 millimeters.
Aortic root from. I mean, I think you explained the 42 millimeters. If you go back to that echo, you said that you had to clarify with the physician
Correct.
what the ascending aorta measurement was. If I'm not mistaken, that's what you said on the call.
That is correct. This is talking about the next one.
Oh,
Of
the 24. So proximal to the treated zone.
Because really that was treated as well if we did the whole.
Right. And the treated zone you indicated in the device list was below the STJ to the STJ to mid ascending, correct? Or to the mid distal. I can't remember exactly what
It
you
is
meant.
supposed to be mid to distal. You're correct. I updated it and I didn't get my slide over in time for the talk. But is this question right here, this proximal to the treated zone, is that talking about the maximum treated zone or just any?
It's the zone that's the zone that's just proximal to the treated zone, and you enter that the largest diameter of that zone. So it's the one right proximal to the treated zone. That's what it means.
Okay, I'm gonna go back so I can make sure I understand this, but I'll get back and then we can re-review it in our next call when we do more aorta if I got that wrong.
Nancy, do you have anything to add?
Yeah, so proximal to treated zone, largest diameter available. So in adult, if we don't have a measurement for the proximal zone, then this is something we would leave blank. And if your treated zone was below the STJ, this is where you would put, if you had an annular measurement, but usually you don't have that measurement. So This is, we would leave it blank in that case. If
Yeah,
you didn't have a
just say
measurement for
no.
the
Just
zone
say-
proximal to the treated.
So just say no if you don't have it.
Yeah, yeah, you're correct. Sorry about that.
I'm not sure that you, I'm looking at that echo. I wish the echo was on the same slide. 'Cause
Wait,
I-
which
Yeah.
slide was it? Hold on.
Yeah,
I'm trying to, wait,
And-
where's the echo? Which slide was it?
I think it's a slide back or two.
Yeah, it's a couple of slides back because I do have an annual measurement.
That's not it,
So
right?
you have
You
the
have-
annulus measurement.
you do have the annulus measurement.
Yeah, that makes sense that it should be not, it shouldn't be the one that I listed as I have this one. Oops, you can't see my cursor, my bad. Sorry. I have the wrong measurement listed. If we had this annular measurement, then that would be the zone proximal to the treated zone, correct?
Correct.
Okay. So, good question. I have the wrong information listed there. I have the wrong zone, right?
Yeah, that's what I'm thinking, since in the device list, I noticed that you put the treated zone as below the STJ, and I guess I'm sorry, I didn't think I noticed that yesterday when you sent these to me, Leslie.
It's okay. I'll update it. This was based off a real case, so I need to go back and make sure I have it correct in my actual information. So I appreciate the feedback.
Yeah. Marina was just saying, wouldn't the annulus measurement be 18?
Mhm.
Right.
Okie dokie.
Yep,
Great.
I just did the wrong one. Thank you for pointing that out.
Yeah, no, great discussion. Thank you. Great question. Thank you. Alrighty, let's see here. Next, could you maybe consider sending out the scenarios before the meeting so we can try and take a look at our notes and the TM to come to conclusion? I feel like I would learn more by trying to complete, and then if I can enter my choices during the meeting, then I may need, then I made incorrect ones. I might be able to work through it or ask a question during the meeting. Thank you for that feedback, and we can discuss that for sure. We would have to work with our marketing team in order to do that, so can certainly discuss that possibility with them.
It is a plan for AQO. We've done that in the past. So if you're attending AQO, that is it's
Yeah.
easy, I think, to do that with the AQO list of attendees rather than the entire list of people who could join these calls. But I agree, it's easier to work through these ahead of time too.
All right, and while we are waiting for additional questions, let me see here. For the next webinars, our next monthly webinar is 8/20, August 20th at 12 p.m. Central. And then we have one on the calendar for the week right after AQO, September the 17th at 12 p.m. Central. So as of right now, that one's still on the calendar. I think unless, you know, we're all just completely brain dead after AQO, we'll keep that one on the books and maybe just wrap up some things, you know, questions and things that we had after AQO. So 8/20 and 9/17 are our next monthly webinars, and contact information here. Again, just for clinical questions, be sure to submit those to sts.org via the clinical, or submit them via the clinical question request form. I have the link included there. So again, clinical questions should be submitted via the clinical question request form, and so just send those directly. Chastity and Leslie do not have access to help desk or STSDB emails. They can answer, they have their own mailbox where these questions go directly to. And then also, if you join the call a little later, after Leslie got started, I did mention that AQO, the agenda is now posted within the platform. So you can view the agenda within the platform. So that is available for each of the databases. We have our Intermax General Thoracic, Adult Cardiac, And then our congenital agenda is here. So you can see what we will be presenting at AQO this year. So we look forward to having you all join us. Also, there was one other thing that I wanted to mention. So I've had the question if for congenital sites, if there's anything happening on Thursday that you all may want to attend. So the answer to that is yes, we are having our reception on Thursday evening. So if you can get in a little earlier on Thursday, we would love to have you at our networking reception on Thursday evening. So please join us for that. But again, our agendas are posted and available out on the STS website. And I'm not seeing any additional questions come in. So thank you. I think we'll go ahead and wrap it up. Anyone else, Chastity, Leslie, did you guys have anything else you wanted to share or anything anyone else failed to mention? Going once, going twice? Wait, do I have another question? Oh, okay. Thank you for the educational portion. Yes, thank you. Leslie, you did an amazing job with today's presentations. I know it took you a while to get all of this together. Thank you, Melinda, and Nancy for helping and being a part of the discussion today. We appreciate you all, and Chastity. Dr. Meyer, thank you for joining. We appreciate you having you on as well. So thanks everyone to my STS team for joining. And with that, I hope you guys have a great rest of your week, and we will see you all next time. Appreciate it. Hope you guys have a great rest of your week. Thanks, everyone.
Thanks, Lynn.
Thank you.
Bye, thank you.
Bye.